OsteoSignal Episode 12. This is OsteoSignal with Neal D O'Neal, a podcast exploring how your body's natural design connects with osteopathic science. Translating complex signals into practical insights so you can truly thrive.
Why hands still matter. If neurodegeneration is a failure of signal, then the next question is simple. How do we influence signal in a living human? Welcome back to OsteoSignal. I'm Neal O'Neal, manual physical therapist. With me is Brent Mayberry and Autumn Mayberry.
Hey there.
In the last episode, we explored how neurodegeneration, especially Alzheimer's, may be less about plaque and more about charge collapse. Today, we take the next step, because if charge matters, if coherence matters, if signal integrity matters, then manual therapy can no longer be dismissed as mechanical care. It becomes electrical medicine.
That's a fascinating concept to think of medicine as electrical, especially with your body's signals.
Right. I mean, and that's just it, is that so often integrating the whole person and understanding there's chemical messaging, there's electrical messaging, but then that messaging is also biomechanical, not just forces, but how do you drive fluids through the human body? And how do those fluids be recognized, or the concentrations of those fluids be recognized? And how does that change human function? And it really is understanding that for patients, and understanding, like, you think electrical, you think, electrical stimulation or some like a magnetic thing on your head or something. But that electrical signal is present throughout your body. And it's not just the neurons themselves. It's what kind of electrical signal do the chemicals bring? Then your tissues respond to that electrochemical message, and they respond electrochemically, and then they change how they function electrically. So health is really in the details of electrical, biomechanical, and chemical.
Mm-hmm.
Very cool. So you said that manual therapy can't be, it can't just be dismissed as mechanical treatment. Can you talk a little bit more about the difference between mechanical treatment and electrical treatment, maybe?
Okay, so typically in the past, manual therapy, you think, we're working on a muscle, we're working on a joint, we're just making something work better so that somebody can throw a ball better, or that they can, sit down in their car better. What patients don't understand, and maybe even medical professionals don't quite understand, is that how you mechanically move determines the electrical flow of information through your body. So the ability to sit and not have aching come on, or not have a body part dysfunction in a way that it causes pain. And a lot of people will say, I must have a disc problem, I have pain down my leg. But that's not necessarily the case. Those nerves can be firing, not because there's a problem up at the disc, but because the hamstrings are firing, or there's extra heat in the system that changes the chemical milieu of what's going on. So the nerve begins firing because it thinks that's the signal to say something. And then that information is read as pain in the brain. So, and using manual treatment to change that. It's like, how do I manually change how a hip works? So for example, when somebody is sitting there, say in a car for long periods of time, and their back or their hip starts to ache, it's that electrical signal, because of the heat, because of the chemicals building up. If I can go in and change how that person's hip works so that it slightly pumps while they're sitting there, as they're even just in a quote unquote resting position, that mixes the fluids, that changes the electrical signal. It allows electricity to flow through an area that it's supposed to flow through. And people might not understand that fascia is an insulator between electrical charge. Like, there are certain places, like certain muscles, you want charge to be flowing through so that they'll fire appropriately. And there's other areas that you don't want to get electrical flow through, because it'll build up charge and then cause, say, a nerve to fire, giving the central nervous system a signal that actually doesn't mean anything. So it's aberrant information coming in. So in a lot of ways, what we're doing with manual treatment is we're trying to restore appropriate signaling so that the wrong signal doesn't come in and the patient doesn't think they're in pain, or information comes in and the body thinks that there's something to respond to. So then it starts responding by firing a different set of muscles. And pretty soon they're like, my their right hamstring, they're driving and they're using the accelerator. So their right hamstrings are getting tight and getting irritated, and it causes their left upper neck to fire in coordination with that. And then pretty soon they're saying, I get such a neck ache driving. I don't understand. And of course they want to focus on the treatment here, not understanding that there's this biomechanical relationship of what's going on with the activity they're doing in multiple areas, and the signaling between those is inappropriate. And
So Neal, is it Sorry.
No, no.
Is the fascia neutral then, or is it charged itself?
It's charged on one side or the other. So it's an insulator,
Okay.
but it's
Okay.
also charged. And it also, as we talked about last week with biofilms, like a biofilm is something that separates charge and separates chemicals from going one side to the other. For example, your genitourinary tract. One of the reasons you don't get infections is you have a barrier, or the cardiorespiratory system. Your respiratory tract has a barrier so that even if something comes in there and lands, it doesn't cause a signal.
Right. Mm-hmm.
Right. Okay. Does that answer your question?
Yes. Yes.
Okay. So moving on. So let's talk about that a little bit. The false divide: mechanics versus electricity. Modern medicine treats mechanics and electricity as separate domains. Orthopedics handles structure. Neurology handles electricity. Biochemistry handles molecules. But biology never made those separations. Mechanical deformation alters ion channels. Fascial tension changes electrical resistance. Fluid movement redistributes ions. Pressure gradients shape calcium flow. There is no such thing as just mechanical input. Those are all interrelated and interwoven. Every mechanical intervention has an electrical consequence. So maybe to better answer your question, Brent, that there is a mechanical intervention or every mechanical aspect of your body has electrical aspects of it, that there's signaling going on back and forth. And oftentimes the fascia is separating that charge out and directing it. And maybe that directs it by producing nitric oxide, right? And causing blood flow to increase in an area. That's an example of not only a chemical, but then nitric oxide is a charged particle, so it will react and cause this this changing in the diameter of the arteries or the capillary bed at that point. Okay.
Can I ask you a quick question about that mechanics? Is that does that apply to just a person's movement as well? Like a person's movement also has an electrical consequence. It's not just an external mechanical intervention. Does that make sense?
Right. So many people have heard the saying, stillness is death, movement is life, motion is lotion, et cetera, et cetera. And that's exactly what is meant by that, that it's not just you're moving your body and that's good for you, but why on a deeper basis, why is that true? And then we kind of go back to this. Mechanical deformation alters ion channels. Like, how do ions, charged particles, flow in and out of your cells themselves? How do they flow in and out of certain compartments within your body? Fascial tension changes electrical resistance. That resistance goes up and down, sometimes too high, because there also has to be an ability of a signal to overcome a barrier to get its signal through. If that barrier is too high, you never get the signal like, hey, you're hurting yourself by doing this. And then somebody breaks tissue down. Or the fluid movement. For example, when you're moving along, just going for a walk, and you're moving that fluid in your abdomen because your psoas muscles are turginating. They're going back and forth. That changes calcium flow. That changes how calcium and calcium, most people may not understand. Every cell in your body, the way that a muscle fires is that the calcium channels open up. That's why with heart muscle, when somebody has a problem, we have calcium channel blockers. Too much heart force, and they're destroying their heart. So yeah, so there's this. You can see how it's not just the biomechanical. Like, oh, it's just muscles and joints moving. No, it's how does your heart function? How do your kidneys function? How do your abdominal contents function? How does your diaphragm function? So all that's very important and interrelated.
Awesome. So it's both. It's both what a manual therapist can do from the outside, but also your body, you yourself moving.
You yourself
also
moving
creates those electrical, effects in your body.
Exactly. So the person moving, and then that's our job as manual therapists is say, oh, you're moving through space and you're doing some of that, but let's say there's some portion of it you're not doing. Your hip is not quite working properly. It's not rotating within the hip itself. Then you don't get as much motion and electrical flow as you should. So if we go in there and we change that underlying ability to move, now all of a sudden that improves, ion channel function in the abdominal, in the abdomen, in the viscera there. So now all of a sudden your kidney gets pumped better. There's no inflammation around it. It makes it easier for that kidney to do its job of moving electrolytes back and forth in and out of your bloodstream. So yeah, not only the motion of the patient themselves, but then how do we as manual therapists improve that motion to make them more efficient, to make them more like they were when they were younger? So kind of back to the idea of our job is to make patients young as old as possible. Okay. So let's state something plainly. The human body is not an inert structure. I mean, you all kind of know that. It is a saline solution. It's filled with polarized membranes, a structure that would otherwise bar ions from going one direction. And by being polarized, it'll let positive ions through, but not negative ions through. So polarized. It's wrapped in conductive connective tissue, the fascia. It's driven by oscillatory rhythms, walking, running, regular motions, breathing. And fascia is not insulation. It is a signal transmitting matrix. But in any signal transmission, it helps determine the direction and the level of that flow. Okay. And
So I just want to go back. I think maybe earlier you said that fascia was insulation, but it's not.
well, it's insulatory. It has insulatory properties, but those properties change depending on what's going on. If the fascia is working properly, it will let certain signals through. There's always some barrier, right? The fascia is supposed to keep, like for example, the best example is certain muscle groups are wrapped in fascia to maintain signal integrity. So when you fire your hip flexors, you only want hip flexors to fire. You don't want inadvertent extra firing of your hip abductors or your hip adductors. You only want those to fire when your nerves told them to fire. But if the signal gets through that fascia and then leaks into the other container, the other compartment, then both sets of muscles will fire at the same time and you won't be as efficient in your gait. So the fascia is insulatory to a level, but it also has to, only to a level, and that level has to be able to go down as well as go up, or it has to define like only for positive ions, only for negative ions, or only for large molecules. We don't want large molecules, for example, bacteria getting through here. So it will insulate against bacteria getting in, which are also electrically driven and
Awesome.
chemically driven, right? So it is insulation, but it has to be adaptive insulation.
Fascinating. That's cool. I think that might be a good topic for another podcast about
About
just
fascia.
how fascia both insulates on one level, but also allows, transmits on another level.
Yeah.
Okay.
Yeah, that'd be a great idea. I'll write that down.
Okay.
So we see in this that fluids are not passive. They are ionic highways, right? They're information highways. So when degeneration occurs, it's not just neurons dying, it's conductivity degrading. And as that conductivity degrades, you get less and less signal, less and less integration, less and less function. So we can see, for example, since we're speaking about neurodegeneration, that a coordinated central nervous system becomes less coordinated. And that might show itself, right, in shaking. It might show itself in memory loss. It might show itself in aphasia, inability to pick out words, or maybe a person will be able to hear, but they won't be able to correlate what they're hearing. And so they go, what? And so it's, so how many times have you said, well, I think somebody needs some hearing aids? And it's not that they can't hear, it's that they can't process at speed. And so they get lost on the words.
All right. Could I just ask a question? You gave some examples of degraded conductivity.
Mhm.
Are you going to talk about what happens in the body that creates those circumstances for that?
Yes.
Okay. Just wanted to make sure. It's a lack of fluid drive or, some other things that you might discuss.
Well, and in some ways, we're already kind of presaging that, saying, well, this biomechanical function helps determine electrical flow. And if that electrical flow is off, so for example, neurodegeneration, central nervous system in the brain, if the cranial mechanism doesn't work, if the fascia of the brain, otherwise known as the falx and the tentorium, they're not able to regulate how much they insulate and how much they transmit, if they're not mobile enough, if they're dysfunctional. Dysfunction, it becomes a really odd thing. You say, oh, well, I thought dysfunction was just like a joint is stuck or a muscle has gotten inflamed. Well, but even the fascia and the fascia of the skull can do that, where it gets stuck for whatever reason, like whatever it is however it is that it functions. In the example of the skull, there are multiple bones that are connected to this fascia, and this fascia's, cerebral spinal fluid is being produced. And so what happens is the fascia moves and has a coordinated pattern of, it almost looks like breathing, right? Because it's flexing and extending, and it's causing a fluid flow so that the cerebral spinal fluid moves around the central nervous system and then weeps out of the system on a regular basis, so that health and cleanliness of the tissues are all maintained. And if we lose that, then all of a sudden the brain stops functioning properly. It stops coordinating its function. And even small drops in coordination of function or removal of waste products, et cetera, results in degradation of function, right? So the brain or the central nervous system won't function as well. And so just simple things like that. So, but when we look at that, we say, well, well, then what affects the base of the skull? Well, even the hand, the thumb, and how people manipulate is going to affect up the arm through the fascia and the connections, biomechanical connections up into the skull. And it's going to deform that reciprocal tension membrane, the dura mater, and it will cause it to only function in one direction and not in both directions. And so you won't get this regular fluid flow that provides health, that provides clear signaling, right? So that's where it becomes the problem. So our real solution here is going through the system and understanding what somebody might come in with a thumb problem and say, how is that going to affect their central nervous system? And it's signal processing. How well can the central nervous system do its job? And so the patient might say, well, this has nothing to do with it, but I get these headaches, and then I have a thumb problem. Oh, and then my hip aches when I drive. How do we put those things together and see a coordinated pattern of here's how the body has broken down or stopped functioning maximally biomechanically. So how will that also affect its neurological or electrical signaling, and how can we improve that? Right. So, and then of course, if there's frank pathology, if something's completely, if it's gone too far with something, there's no restoring that, but you may be able to slow down the process or at least clean up the edges of that and make it a minimal interference. Right. So there's different levels of what it is we can achieve just with manual therapy, just with what we're trying to do with the body of restoring thumb function, shoulder function, base of skull function, and hip function.
So by frank pathology, you mean like something like, I don't know, cancer or
a stroke,
something that's not just, chronic sitting or
right.
Like an evolution of dysfunction does that make sense? Like something that started small and just kind of cascading over time due to age or activity level or something like that.
Right. Dysfunction itself does not cause pathology. Pathology is where something is broken. Now, we say that, like, for example, cancer is not caused by poor sitting posture. That's not how that works. But if you're bathed in chemicals, let's say that you get exposed to certain chemicals and they're not moved out of the system in a timely manner, if those chemicals sit around, they would have a time to act on the DNA, and they're going to have a greater and greater effect on that DNA over time. So that might lead to cancer. So it's not that you had poor sitting posture. It's that you didn't move something else out or help the cell recover.
Yeah. I was just trying to make a distinction between, frank pathology, like something obviously wrong and that between, dysfunction that comes with life habits or things like that.
Yeah. I mean, you can't have dysfunction that's so bad that at some point you compensate, and compensate means there's adaptation and there's compensation. And if your body is constantly adapting to whatever situation is going on, and that's something that's easy for us as manual therapists to like, oh, okay, we go in and we restore that function, the adaptation goes away and the person functions better. The compensation is where, say that you've rolled your ankle a bunch of times and then you walk on your foot oddly, and pretty soon there's a degradation of the knee surface. Once that degradation has gone far enough, it is now frank pathology. And we call it's compensated. There's nothing we can do about that frank pathology. And people say, oh, yes, I have worn a hole in my meniscus, right? So you'll say, oh, I have degenerative joint disease of my knee. I've worn away the cartilaginous surface. I'm becoming bone on bone. We can't restore that cartilage once it's been worn through. That's frank pathology. However, if that doesn't mean that you don't still have a thin film of fluid that your weight is borne on. And if we can restore that, then people say, well, it's funny. I did an MRI or whatever, and I know that I have frank pathology of my knee. However, you worked on my knee and I feel much better. And people say, oh, you healed it, you fixed it. It's like, well, we made the system work more like it's supposed to. I can't restore that frank pathology of the meniscus or the cartilage. However, I can make it so that doesn't matter nearly as much.
Gotcha.
Yeah. So frank pathology is broken. No fixing. Yeah. That doesn't mean we can't make it better or make it adaptive enough that you don't feel that. And that is what we're kind of talking about here with this, the conductive medium of the body that oftentimes there might be scars, like you've injured yourself and there's some scar that no signal is getting through there. Well, we're going to go and work on that and work on the body so that maybe the body can work around that. It can adapt to that frank pathology and say, okay, that frank pathology is a problem, but it's not nearly the problem that it was. So instead of being this problem that's way up here and, I have this problem here and I can't play pickleball or I can't do whatever. Now I can actually play pickleball and I have minimal problem with it. So that's what we're talking about.
I tell my patients all the time, we don't fix the frank pathology stuff, but we help you cope with it better, right?
Right.
We can fix
Right.
dysfunction, but we want to maximize whatever resources you still have available in the body to make it you thrive better with whatever you've got.
Exactly. Exactly. Okay. Neurodegeneration is loss of coherence, right? And so there's a lot of signals going on in your body, and what it is that causes us to function properly and have our organs and our organ systems, and then this whole organism thrive and survive, not only just survive, but thrive, is the coherence of the signals. Like, how coherent is all this going on in our bodies? And then that's how much we're thriving or not. And so and what we call that is coherence of signal. So before neurons die, something else happens. Brain rhythms lose synchronization. Calcium signaling becomes noisy. Mitochondria lose membrane potential. And if you can't, the mitochondria produce energy for your cells. And if their membranes lose their potential, you lose the ability to produce energy for the cells. So then the cell is like a manufacturing plant that can only work at 75 or 60%. Not helpful. Okay. Axonal transport slows. So the axon is the long part of a nerve, right? So you have a nerve body, say in your spinal cord, and then it goes all the way down to your big toe, or to a big toe muscle. That axon is supposed to transport nutrients down the end, signals, chemical signals to tell that muscle to fire. Well, if that axon cannot transport nutrients fast enough, a person that has been walking all of a sudden loses the ability to walk well or as efficiently, because now all of a sudden their big toe doesn't fire and their gait is not as efficient. Now that costs them more oxygen. And so they start breathing heavy and they say, oh gosh, I have shortness of breath. I can't walk 2 miles. I can't walk a mile. I can't even walk down the hallway. Axonal transport slows. Receptive signaling fades. And interoception is the ability to sense of what's going on in your own body. And so a lot of patients come in and say, oh, I have incontinence. One of the reasons for incontinence is that they don't realize as early as they did in the past, hey, I'm going to have to go to the bathroom, or, something else is going on. So they lose that ability to control certain things because by the time they're aware of it, it's so desperate that it has to happen now. You need to go to the bathroom now. Or, gosh, I was feeling fine and now all of a sudden I'm horribly thirsty. Like, what happened? Well, you lose that interoception. You lose the sense of what's going on in your own body. Okay. And that's not structural collapse. It's a coherence collapse. You're not getting, the signals are there. They're just being blocked or, it's like static in the air. You can't hear the signal coherently. And so you don't know, it's not information until the information's a tower, and then it's desperate, or it's not that smooth functioning of life that we've all become accustomed to living. When you're younger, there's lots of coherence and you're very used to that. And so as the signal fades because of problems and whatnot, then all of a sudden you're like, why is my digestion so bad? Why is why is this not working? Why is that not working? Okay. So coherence is a property of electrical systems, not part lists, not biceps, triceps, AC joint, glenohumeral joint. So what manual therapy actually does, let's strip away the marketing language. Manual therapy does 5 fundamental things. It alters pressure gradients. It changes fluid flow, modulates autonomic tone, right? Affects membrane tension and influences ion channel behavior. And those are all like, okay, what does that mean? So pressure gradients, chemical processes flow in a certain direction because of pressure gradients. For example, how much oxygen is in your bloodstream? If there's more oxygen in your lungs, then oxygen is forced into your bloodstream. Your hemoglobin can pick that up. There's even some partial pressure of oxygen into your blood plasma. If the carbon dioxide builds, then you have greater amounts of carbon dioxide in your blood, in the blood plasma, and in your hemoglobin. So your whichever way those chemicals are, the pressure gradient goes, that's which way we direct that. So you would think, oh, in a vein, lots of carbon dioxide, the pressure gradient is going to be one direction. In an artery or in the lung, you're taking, oxygen poor blood and you're bringing it to the lung, and the lung is going to say, hey, look, I've got lots of oxygen here and you have none there. The pressure gradient is going to force oxygen into your blood at that point.
Right. So, and a gradient is just a difference.
Yeah.
Like a high to low or low to high.
Exactly. It's a ramp. Yeah.
Yeah.
Does it go up or, yeah, you have to go up to get there, or is it a free ride? You got to go down, right? So that's a pressure gradient. And the body uses those pressure gradients. It builds up pressure in one area to cause something to happen over here. Inflammation is a big example of that. And which is why they say when people are having heart problems, the doctor might say, oh, let's give you a water pill. Let's get the fluid out of here because it's creating such a pressure gradient. Your ankles are huge. Right?
Gotcha. Could you maybe just briefly mention what, a technique that manual therapists used that achieves, an alteration of a pressure gradient? What's
Sure.
something that manual therapists do to affect that?
Well, one of the biggest things that we do is, for example, one of the things that people may not realize is that 3/4 of the body's lymphatic fluid drains into the left thoracic inlet. And so there's this huge pressure gradient that here there will be a bunch of pressure. In fact, some people actually get a little bubble of fluid above their collarbone where that fluid is supposed to be coming up over the first rib and going down back into the heart. And so if that happens, they'll get a lot of fluid there. So there's this pressure gradient where there's you basically can't push lymphatic fluid through the chest. And so then pretty soon people are wheezing, right? So you'll have a chest that's congested and wheezing. So if you open up this valve here, basically, and get that to flow, the fluid in the chest will all flow to that because of the pressure, right? The pressure is highest at the farthest away. And as it is able to push on that, if the pressure is low here and high at your diaphragm, then what you'll get is you'll get a flow of a net flow of fluid out of that area. So what we'll do is we'll not only open up the thoracic inlet, but we'll also work on the diaphragm so that both ends can push the fluid, so that this end will suck the fluid and this end will push the fluid. The bottom end will push the fluid. So that's a pressure gradient. And so we'll look at both ends of that and say, where's the drain? Where's the pump? Or where's the siphon? Where's the pump?
Mm-hmm.
Okay? So that's what we do with pressure gradients. Same thing at the foot and ankle. The foot and ankle cannot, if there's a ton of pressure there, and you'll see like someone will have enlarged ankles. If they have enlarged ankles, one of the first things we would do is release the inguinal ligament at the hip, because that's where the lymphatics flow up through. And then we would work on the foot and ankle itself so that we've worked on the siphon of where the inguinal ligament is, right? That area sucks the fluid up there, and the foot and ankle will push the fluid up there. So the pressure gradient is from the foot ankle up to the hip and pelvis. That's a real common one for manual therapy. And that what we're after for health, because people have fluid on their legs, they can't walk very well, they have poor sensation, their nerves become dead, it's painful, right? And at the end of the day, when you have fluid in your ankles like that, that is congestive heart failure. That is the definition of congestive heart failure. Yeah, most people don't understand. Congestive heart failure is not about the heart. The heart is the last thing in the line, so it's somewhat misnamed in that the heart is the last structure in the line, that when the fluid backs up all the way around the system to the heart can no longer pump and the heart dies. So the heart is trying to push blood, and the blood flows out and then flows back and hits the heart, hits at the nose, and the heart's like, ow. And you keep doing that. So that starts the whole process of congestive heart failure. But the thing pushing the fluid, the arterial blood back into the heart's face, is the peripheral resistance of the fluid in the foot and ankle, or any of the capillary beds. It can be the brain, the capillary bed of the brain, the capillary bed of the liver, such as alcoholic or non-alcoholic fatty liver syndrome, right? You'll have fatty liver problems, and that the heart is trying to push blood through there, and then the liver can't accept that blood, so it shoves it back at the heart. Yeah, so that's a pressure gradient, right? That the heart goes to push blood into the gradient, and the gradient pushes it right back and hurts the heart.
I just had this in a newborn that was jaundiced really badly, and the mom had been on Pitocin, and it really crammed that baby. And we stripped the baby down, and it had little blotchy spots, and like the diaphragm was different color below the diaphragm as above the diaphragm. The arms were purple. The baby was just yellow all over the place. And we repositioned the liver because it was bulging out from underneath the diaphragm, and just kind of repositioned things there, got the fluid to flow, and then the baby's all of a sudden pink. And you're like, and they're off the lights, So it's the same thing, like little kids, and the head stopped bulging, and the neck was thinner, and the baby was about a half an inch longer by the time we were done. So it's pretty amazing how quickly it can change things.
Yeah, that is amazing. Great job.
Mm-hmm.
I mean, and that's just it. I mean, that's
thanks, Neal.
Well, it's things like that you just see how powerful this work can be, and you go, my God, in a baby that's under bilirubin lights, et cetera, and failure to thrive, et cetera, and then you go in and you remove that pressure gradient and allow the pressure to flow, and what do we get? We get health, we get survival, we get thrival. We get the patient thrived.
And we didn't beat the kid up. We just used these gentle stretching things and help kind of lean the body certain ways to release that pressure, change the electrical gradient. We weren't bumping on the kid either. It just, and those things will move. That's why those three, like the electrical, chemical, biomechanical, they all function together. You're always doing all three. So
Exactly.
you don't have to beat them up.
Well, and that's just it. On social media, I see all the time that, there's somebody who is like, wait, have back pain, crack, like, do this fun thing to crack it. And it's like, that's great. It cracks for the second, but does that restore, that restores biomechanical, but does that change biochemical? Does that change bioelectrical? Does it alter pressure gradients? Does it change fluid flow? Does it modulate the autonomic tone? Maybe for a second or for a few minutes, but then that problem is right back because you didn't treat where it's coming and going to, and you didn't treat around the problem. You treated one little area, and you treated where the pain was. And as we've said in previous posts, pain is a liar. Pain shows up wherever you have hypermobility, and it's where you have hypomobility or the wrong side of a pressure gradient, right? The back end of a pressure gradient is going to ache. The front end, where the fluid needs to flow to, doesn't ache because nothing's moving there. It's all deadened, and it doesn't give you a signal. I mean, that's the whole point, is where you're not getting the signal. The real problem is here. The only signal you're getting is back in the back where it's moving too much, but that's not really helping you. I mean, it helps you temporarily, but it doesn't fix it long term. Like with the baby, like, we're going to do bilirubin lights. That breaks down the bile or the pigmentation in the bloodstream. It helps the excess hemoglobin and whatnot. But it doesn't fix that the liver is not processing properly, right? Where the signal was lost was in the liver. The liver's inability to biochemically alter, bioelectrically alter the fluids in there and break them down, draw that stuff out, and then push that either into the colon or the kidneys and get rid of it, which is what you did. You removed the pressure gradient. You changed the fluid flow. You modulated the autonomic tone because you made the sympathetics and the parasympathetics work together again. You affected the membrane tension. The membrane, the liver is in a capsule. And if that capsule is too rigid, it doesn't let fluid in and out of it. And so now part of the lymphatic drainage of the liver doesn't function. Well, if there's a pressure gradient to the liver itself with its own lymphatic drainage, it certainly can't help the bloodstream get rid of excess hemoglobin, right? And then, influences the ion channel behavior of the hepatocytes themselves. Like the hepatocytes themselves then couldn't do their job of this ion stays and that ion goes, and we play this, and then your kidneys go and play a trick where we push this ion over here and it draws something up, and then we pull it back and then this gets stuck, right? The kidneys have to play a biochemical game, bioelectrically, right? Because it's using charged particles, charged ions to cause that. So that ion channel behavior. So that's exactly what you did. Now, that sounds like a lot of talk for saying, well, I worked on this kid's liver and I made their diaphragm work and I did this and I did that. But that's in manual therapy, we tend to have a biomechanical vocabulary, but that doesn't mean that the understanding that you have of what you were doing isn't exactly what we're talking about here. You understood all these things, which is what we want other people to understand, that there's a much deeper, which is why you often have Western medicine throwing simple fixes like, hey, we'll just throw this chemical at it. A chemical is not going to fix both sides of the problem. You have to look at both sides of the problem, the top side, the back side, the right side, the left side, the front side. There's multiple angles here that have to be looked at, just like here. I mean, ion channels, well, what is the chemical going to do for that? What if that chemical can't get to the ion channel because of the inflammation in the liver? Which medication were they going to give the liver to make this kid better? They're not until 30, 40 years down the road and say, well, we don't understand why you have liver dysfunction. We don't understand why you have hepatic dysfunction. Why do you have a fatty liver? Why is your liver not processing this? Well, it might go all the way back to birth, and that the person was the child was jaundiced, and nobody restored that function, and so that liver functioned, but it never functioned at its optimal again. And then, not so long later in life, here it is breaking down and not functioning properly, and everyone's going, we don't understand why people get this. Like, why do people get non-alcoholic fatty liver? Like, well, here's a reason why. That if we go back through their history and say, well, because their liver was never treated properly, it got beat up through birth, it didn't function, there were altered pressure gradients, it wasn't restored, and that follows through with life. And the liver does, and everyone goes, no, but in between their liver was fine. No, the labs were fine. That's because every liver cell was doing its best. The ones that could functioned at whatever they could, and you have lots of excess. But here the person is at 40 or 50 and they have fatty liver. And we're going, oh, gee, we don't know why this person got that fatty liver. Well, let's go back through the process. And then the treatment for that person is still going to be this. Unfortunately, by that point, there is some frank pathology. Now you've broken down the liver such that there may be cirrhosis, there may be scarring, there may be other problems that we've caused with that liver. Plus, there's other things that have gone through life, like how healthy was that liver when this person got Epstein-Barr virus, or how healthy was that liver when this person became ill and needed to process things, and so it degraded the liver. So you have advanced aging of the liver. When had we treated this problem just like you did for this child at birth, well, there's no way for you and I to go and say, well, we want to see the next 80 years of this kid's life and see how, like, what would it have been had you not fixed their liver, and what would it have been had you, that you fixed their liver. We're not going to know that. But I think from this information, we can make a pretty good educated guess as to saying, I think what you did is you just altered the course of that child's life. I would be extraordinarily surprised if that kid had fatty liver in 50, 60 years.
Mm-hmm. Well, and I've watched you in class over many years, Neal, where you're finding stuff and people are like, I have this weird pain and I have this and that. And then you're able to pick up on stuff that, yeah, if we leave it unchecked, then eventually the labs will pick it up. Right now, they're not going to, but we can, that it's still dysfunctional. And but with that sensitivity that you acquire with your hands, and you have a natural gift for this too, but you can pick up on stuff and be like, well, years down the road, it'll be Crohn's, or years down the road, it'll be this. But right now we can stop it. We can get that internal milieu to reset, and then prolong, thriving and do a lot better and alter that, instead of, we don't have to go that far. We don't have to go that far, because those labs aren't going to pick it up till much, much later when it's really damage control.
Right. Exactly. And I have, Autumn and I share patients, or share, family related patients. And so I do get to hear their stories of some of the stuff you're doing, and awesome things like with this. No, awesome things.
Yeah.
When you've treated patients and they're like, it was amazing. Yeah. She did this and she did that. And it's like, it's not that just that I have a gift for it. It's that understanding exactly what we're talking about here, about the interrelatedness of this, and exactly what is the science of how this works. Like, how do bodies work? It's this coherence of signal. And that's what we do. We restore coherence of signal. We go through the body and we look for the lack of coherence, and we say, this is a problem. We need to restore that. And that's very teachable.
Yeah, it is. And then you got to put in the time to practice.
Yeah.
And get that feel for it too. You look and then you feel too, right?
But it would also help and that's why this podcast is as much for patients as it is for healthcare professionals, because if the patients don't know about this, they can't demand this care. And then no one will do this, because they're like, hey, I make as much or more money by not knowing this than I do by knowing it. But it doesn't help patients. But if the patient doesn't demand it, then that's, they're just not going to get more out of the system than they demand of the system.
Yeah, they don't know there's a whole lot that can be done to make them feel better a whole lot sooner. And even in frank pathology, you can thrive a lot better.
Right. I mean, you minimize the effect of that frank pathology. So maybe you have a hole in your coherence, but if the body can work around that and function, just go, ignore that. We'll just go past it. We'll go around it. We'll do this. And it won't even be a particular problem, or it'll be a minimized problem. And that's the whole thing is I really want patients to hear these podcasts and to understand, you're going to your healthcare practitioners and you're asking for this care. And they're basically, all of them are saying, or most of them are going, nope, not possible. No, that's not how it works. Oh, it works this way. They oversimplify it. They undersell it. They don't understand it themselves.
Trash talk it sometimes.
They totally trash talk it. Going, it can't work. And, and it's the thing. That's one of my pet peeves, is that on the one hand, everyone in medicine is always talking about neuroplasticity. And then you have a stroke patient, they're saying, well, you only have 90 days and then that's it. That's as good as you'll ever get. And it's like, neuroplasticity, hello. Every night humans go and they go to sleep and they heal and they regrow. I mean, in a lot of ways, we are kind of like a tree that, you think about, well, there's the center of the tree that's not necessarily growing. That's the old, not dead, but not, but there's the outside of it that's always growing. There's always a new layer, a new thing. Now, humans grow throughout, not just in a rind like a tree. That's why we're able to move around. But it is that same thing, that every night you heal, every night you recover, every night neuroplasticity and body plasticity occurs. So there's always a chance for that body to be healing. Well, you're always shorter and it only gets worse as you age, or, that's just a problem of aging. That's not necessarily so. There are things that break down with age, because age is exposure to the universe and things happen, chemicals, injuries, et cetera, et cetera. But if we minimize that, the body will grow around that. The body grows back to its best ability. Our job is to maximize that. And patients need to know that you need to demand that. Demand that of your health practitioners, because I'm not the only one teaching this stuff. There's lots of information out there and lots of people who are helping patients, not just in our group, but patients have to demand it more and more of the healthcare practitioners. And then as you see, the more that's demanded, doctors start including that in the information they're providing and start saying, let's have you go see this person or let's have you go see that person. Something can be done about this. It's not all over. So you're getting that more and more in medicine, but it just needs to be pushed, and it has to be pushed by patients. So they have to know what's possible. So that's the reason for us doing this, right?
Yes, exactly.
Yeah. So, and none of those things are musculoskeletal only. They are signal interventions. When done with precision, manual therapy, we reduce background electrical noise, improve signal to noise ratio, and since we're going to put it in that parlance, restores rhythmic coupling, enhances adaptive capacity. Okay. And that's not placebo. That's function. That's real cellular function. Right. Okay. This is the physics applied to biology, right? Physics and chemistry applied to biology. And and that's what we do as manual therapists. We apply the physics, apply the chemistry to the biology and say, here's applied physics biology, right? Okay, so then let's talk a little more about the cranium, the dura, and the electrical regulation. So the cranium is not just a helmet. It's a regulatory interface, right? The dural tension, so that the dura mater means tough mother. So there's a tough mother, a dura mater, around your entire central nervous system. It even goes out to the edges of the nerves to some degree. Okay. That dural tension affects venous outflow. Venous outflow, like how much blood comes out of your skull and how does it do it? Cerebrospinal fluid oscillation. The cerebrospinal fluid is a lot like the plasma in your blood. It doesn't have as many other constituents. It's much cleaner, but it's also spoken about in medical circles by people who know of a healthy fluid, a health driving fluid. So that cerebrospinal fluid oscillation, right, where there's the ebb and flow of the cerebrospinal fluid, so the dural tension affects that. That's one of the things that drives it. Also, what's known as glymphatic exchange. So in the body, we have the lymphatics. And for years, everyone said, well, there's no lymphatics in the brain. And what we've discovered is that the support cells, the neural support cells, like astrocytes, Schwann cells, etc., the microglia, not the neurons, that they actually have a glymphatic exchange. So the dural tension affects that glymphatic exchange. How much fluid, how much waste product do you get out of the skull that's not in the venous outflow? And then also cranial nerve excitability. You might say, well, gee, migraines, chronic sinusitis, parosmia, any problem with a cranial nerve. Those are all cranial nerve excitability, whether they're hypoexcitable or hyperexcitable. You want them to be normoexcitable, right? You don't want you only want the nerves to fire when they're supposed to nerve. That's part of the coherence and the proper signaling. If some nerve is always firing like this person might have headaches. They might have, twitches. They might have all sorts of things. That dural tension affects that. And these systems are electrically sensitive, right? They're sensitive to the electricity. If their cerebrospinal flow is impaired, ionic clearance is impaired. If venous drainage is restricted, charge gradients distort. And those charge gradients, that's how you get a nerve to fire. Like if a neuron gets enough charge gradient, it fires. But if it's being blocked by inflammation, the charge gradient never gets high enough, the neuron never fires, you don't get the proper function. Or the charge gradient is that if the neuron's always excited because there's too many chemicals sitting there and it constantly irritates the neuron, and then that neuron fires and wears everybody out. Oh my gosh, I don't know why I'm just worn out all the time. Well, your brain's working improperly. So neurodegeneration thrives in stagnation, right? Lack of coherence of signal. Manual cranial work restores movement, and movement restores signal clarity. And that's what we do. Again, back to the signal clarity of how do we optimize the system? How do we allow this person to survive and thrive? So then let's talk about a little bit about autonomics, like vagal tone and calcium control. Neurodegeneration is inseparable from autonomic imbalance, right? So the sympathetics and the parasympathetics have to work together to cause ebb and flow of chemicals and hormones and food stock, etc. Sympathetic dominance leads to elevated intracellular calcium, increased oxidative stress, mitochondrial overload. If you have mitochondrial overload, they stop being able to perform their job of providing energy for the cell. Elevated intracellular calcium. Basically, one of the big things is the way that we excite cells is that we allow calcium out of the cell, right? But if a cell becomes so packed with calcium that the calcium can't get out, that cell can't fire properly. It can't get the proper signaling, particularly neurons, right? Neurons are one of the big example we're thinking of, but even muscle cells fire. Well, if they have elevated intracellular calcium, it really is a problem for the cell itself. It starts destroying the cell. So parasympathetic tone. Parasympathetic tone improves calcium regulation, enhances mitochondrial efficiency, supports protein homeostasis, and you have to move proteins in and out of areas. You can't build without proteins. But also remember that proteins, when we move proteins into an area, they suck fluid in with them. Right? There's a law in chemistry that if you have too much of a substance in an area, water is going to be drawn into the area, or whatever fluid is present will be drawn into the area to dilute that, so that two areas will have the same concentrations or nearly the same concentrations. One of the ways that happens is that if there's a protein in an area and you put a bunch of fluid in there, and you have an area over here that doesn't have any protein, then the fluid will shrink in this area and increase in that area, so that at least now the ratio of protein to fluid volume is closer. Even though this side might be 0, this side's closer to 0, even though it's not 0. That makes any sense. And with our hands, we actually change the ability of the body to move proteins around. So, and especially in the brain. Okay, so supports protein homeostasis. Manual therapy that genuinely shifts autonomics is not relaxation. Cranial work is not a relaxation technique. It's not you made the patient, you gave him a spa day. It's not we're not here for relaxation. We're restoring function, right? Ionic regulation. Okay, why this fails when the technique is empty. Here's the hard truth. Manual therapy fails when it's protocol driven instead of signal driven. If you're not responding to what the body's doing and you just are doing a set list, regardless of what the patient says or what the body says, the practitioner won't be successful. The other part is that it chases pain instead of coherence. We're interested in pain, but we can't go, oh gosh, it hurts right here. Would you just rub right here? That's not manual therapy. It's a rub, right? And so we have to be very clear about this, because people do think like, oh, I'll just go to a manual therapist and I'll just rub right here and maybe they'll fix the problem. Well, if you've rubbed it 500 times and hit it with your massage gun, and you've been to 50,000, somebody stuck their elbow in there and that's not changing it, that's not where the problem is. That's where the signal is going wrong, but that's not where the problem is. Okay, so it chases pain.
I was just going to jump in and say, so people seeking, relief from dysfunction need to make sure that their practitioners are looking for signals, right? And not just applying a cookie cutter approach, to treating them. Like, ask your provider, what signals are you observing? What are you seeing?
Right.
What are those signals telling you? What are you going to do? What do you do with those signals? How do you tailor your treatment, to listen?
The needs of that body, right?
Yeah.
Yeah.
So people listening, make sure that you take that into account. Talk to your providers about listening.
And a shameless plug for Neal and my other mentors that have taught us how to do, like, one of my criteria for taking classes from people is I don't take classes from someone who's like, oh, I'm a myofascial person, or I'm a deep tissue. Because everything looks like, that problem. If you have like a favorite thing, and that's the approach you're going to always use to all your patients, and they're not the same. And so, everybody's like, oh, I never know what you're going to do when I come into class. I'm like, yeah, because the people I take classes from, they treat patients instead of get a favorite technique or like a darling this or that they want to go after, and then go after that all the time, and everybody looks the same to them. So we want to be able to be like, yeah, every time someone comes through my door, it's an oral exam. Like, what do you know? What are you going to find? What are you going to look for? And use the tools that we learn from Neal and the mentors we've had that help us distinguish and read those signals and be able to figure out, if a map thing, maybe this electrical problem is because we don't have fluid flow also. Where's the fluid backing up? Those things like that. Shameless plug for, if you're a practitioner, take classes from Neal and the other people that we do. They treat you how you want to be treated. You want your stuff treated, not the last patient before you and the one after. So
yeah, I just wanted to jump in and encourage listeners to do that, to take that approach, make those demands.
No, and I think that's exactly right, because and people will even say, you have practitioners, I see this all the time. They say, oh, we're not protocol driven and we don't chase pain and we listen to your body. And then they promptly go right to their protocol. They go right to their, hey, here's what makes this patient feel good for the minute, right? And then they just, they do their treatment, and it doesn't matter what the body says or what the patient says. Exactly, right? So not only do they have to do, so people ask me all the time, like, oh, how do I find a practitioner? If I don't have someone to refer to them to in the area, they'll say, well, how do I find a practitioner? I say, well, look for these things. But even when they're experiencing their treatment, do you see those things being borne out? Or do they just go right back to, well, we're going to give you to here's the practitioner at our clinic that has time on their hands. So, whether they're any good or not, this is what you get. Okay, so yeah, very, very good point. Thank you, Brent. Okay, so you cannot impose coherence. You must invite it. In a lot of ways, we say you don't treat, we don't fix anything. We open up a pathway for the body to return to its function, and that's very important. That requires perceptual skill, adaptive touch, real-time feedback, respect for the nervous system, understanding, a lot of understanding of how these systems interact. And that's where you gain that respect, practitioner does. That's where they learn to feel for feedback from the body, that as they're pushing, is the body pushing back? Does the body release or say, oh, I will now have that, T5 vertebra rotate appropriately, or, oh, my glenohumeral joint now has the appropriate positioning in the joint. Are they listening to it? All things that patients have to watch for. So this is not technique accumulation. This isn't like, well, I've gone to these 20 classes and we learned these 50 techniques. And so I just pull out those 50 techniques and do them all on you and see which one worked. It's not that. It's clinical maturity. It's professionalism. And so you also have to demand that professional level of treatment. And I think there are a lot of people out there that would provide that, but patients aren't necessarily educated as to what it is they really need. Patients need this. If you really want to get better from something and have health, this is the underlying science of it. And I know patients want that because they constantly go to Dr. Google and say, Dr. Google, what do I need? Right? So, so I know they want it. I know they need it, but they just don't know what it is because nobody's educating them. And so my job is to throw education out there and say, hey, here are the questions and here's some ideas. And maybe if you understand it this way, that may be very helpful to you as well. So, okay. And understanding that their practitioner needs clinical maturity. Okay. So the role of the manual therapist, neurodegeneration does not begin as a disease. It begins as a loss of adaptability. Manual therapists are not treating Alzheimer's, right? I'm not treating Alzheimer's. We're supporting the conditions under which degeneration slows or fails to progress. We're trying to undermine that degeneration so that the body can fix itself. That is subtle. It can be upstream, but it can be very powerful, right? And so, our mentor Bear would do things, and he said, "Well, I oftentimes have patients come in, and they'll say, oh, can my significant other or somebody come watch? Or I have a practitioner that really wants to know what it is that you do." So they would come in and watch, and then pretty soon the person who was supposed to be watching would fall asleep. And he would kind of laugh. And the person like, I thought you were supposed to be watching what he did so you could redo it. And the person like, he wasn't doing anything. It's like, yeah, it's not, you don't have to hammer the patient to change that. A lot of times you're doing this listening. You're doing this adaptive touch, real-time feedback, but you have to be listening with all of your senses. So if the person's just beating on you and there's no, like crack, 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 whip, 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 my favorite, do these monster walks. The latest exercise of great craze is a double clamshell. Oh, you're going to do clamshells? And then we're going to do double clamshells with a big rubber band around your knees. You're going to walk across the room and that fixes everything. That makes Alzheimer's better. Like, where's the feedback? Where's the understanding? Yes, all my patients are coming in. Oh yeah, my hips are really hurting because I've been doing these monster walks. Like, and then my back still hurts. And I don't know. I don't understand why. Okay. So if medicine wants
non-specific treatment.
Yeah, non-specific treatment. So if medicine wants real answers, it must stop ignoring hands. The feedback, the manual feedback, our bodies are very, very sensitive. Autumn, how long have you been doing this?
22 years in February.
22 years. So 22 years of training, of understanding and feeling and training our brains and our hands and our bodies to have perceptual skill, to have adaptive touch, to have real time, to be able to read real-time feedback. And our understanding and respect for the nervous system, 22 years, right? I've been at this over 30 now, 31.
I was saying, I'm starting to get the hang of it now. Neal's really got it down.
One of these days, but that's just it. It does take time to train this. So when you have somebody who's just out of school saying, I'm an expert in this, okay. Yeah, I have a lot of years of doing this. And so that adaptive feedback, that understanding, you don't learn that in school. And just because somebody has a PhD or a professional, degree or whatever, that doesn't give them that knowledge. Doing research projects does not give you that knowledge. And that's one of the biggest problems with what I see on practitioners coming out saying, well, I have a PhD in PT or whatever in general science or chemistry. And I know I'm an engineer. There's the guy on the internet. I'm an engineer and I understand how the body works. I'm going to give you the exercises. So he basically hands out PT exercises. And you're like, you don't know what it is. I mean, people just don't know what they don't know.
Mhm.
Unfortunately, that's a lot of healthcare practitioners. It's not taught in schools. The schools aren't going to make any more money by teaching this. The schools make money by pumping these people out and giving them a certain amount of things and basically making it so that practitioners don't kill patients. After that, it's on the practitioner to learn their craft. But patients have to demand that practitioners learn that craft. And unfortunately, a lot of patients have no idea of where to turn. So I'm hoping that this gives them an idea of like, hey, I want you to be able to do this. I want you to be able to, I want somebody that can do this. And if you can't, I'll find somebody who will. All right. So if medicine wants real answers, we must stop ignoring hands, because hands feel signals before machines detect pathology, before lab tests go wrong. Like you said, that baby, yeah, its liver was functioning just fine as far as they were concerned. It just needed some lights. That's not how it works. So this is OsteoSignal. This is where manual therapy belongs in the future of healthcare. Okay, so coherence is health, loss of coherence is disease. So I guess in closing, I do just want to say that's why patients need to demand this kind of treatment and this kind of knowledge and this kind of integration of systems. I'm not saying we don't need the rest of medicine. We need all that we have, but we need more than just that. It's this, who's coming in and being the person who brings it all together. And I have patients say that to me time and time again. I'm like, well, I come to you when I need somebody to see the whole picture and put it all together, because I have my MD specialist, I've got my ND specialist, I've got my this specialist, I've got that specialist, I've got this specialist, and you're the person I come to and I give you all this information, you put it together and then show me in my body how it's all working or breaking down together and what might be done. And then I try to ask them questions about, okay, well, maybe go back to this person or go back to that professional and ask them this question or ask them that question about what does this have to do with this and what does it have to do with that? What should we do about this? For example, people come in on blood pressure medication, and then all of a sudden we start treating them and their blood pressure is dropping through the floor. It's like, well, you need to go back and talk to your cardiologist about your levels here. Or maybe we find that there's a problem at T10, T11, T12, and when you're having kidney problems or your psoas is constantly tight. Maybe there's a kidney aspect of this. Maybe that blood pressure medication isn't the best for you because it's irritating your kidneys. And we read that signal as, hey, your hip and diaphragm on that one side are just not working and it's very rigid in there. It seems that your kidney may be dysfunctioning. See, being able to read the body and see those signals and be able to determine what's breaking down or what's not responding to the other signals, what body part's not integrating itself into the whole to provide health. And that really is what we bring in and what I would hope that patients can begin to demand of more and more practitioners, so that all practitioners kind of spread out a little bit and have a little bit more adaptive feel for what's going on with the patient.
And I guess maybe some advice I give to patients too is, if you're having labs run, you don't feel well and you don't, life isn't going how it used to be, you've noticed difference or whatever, and you get your labs done and nothing shows up and you're fine, that's probably when you need to find someone like us.
Yes. Yeah.
Because it's not a frank pathology yet. It's not you tore something and on the MRI, well, you have a detached this, we need surgery. It's, I don't know, you should be fine. We don't see anything on that. That's when you need to find us for sure. And then we can do a whole lot with that.
Exactly. You can't see the lack of coherence on a scan. There's no one test that will show you a lack of coherence of signal. It's exactly what the patient comes in and tells you. The patient is the scan. The patient is the one that comes in and says, there's a lack of coherence. I have these problems in all these areas. And how do those fit together? And that's really what we've been trained to do. And we're trying to show other people how to do, but also that patients need they need to know it's out there, demand that. And the more you demand it, the more it'll be there for everyone. And the more effective healthcare is as a whole. Right? And
absolutely.
That's what we're all after. So awesome.
Yeah.
All right.
Awesome.
So
thanks, Neal.
Listeners, thank you, Neal. Just for those watching or listening, let me just say that if any of this resonated with you, and you have some people who are interested in learning how to do this, go to Neal's website, pursuitpt.com, and look for his courses and see if any of those courses look interesting to you, and check them out. Sign up. You can attend via Zoom or in person. He does classes in Seattle and Salt Lake City sometimes. And so, I encourage you to share this, spread this around, help people who need it, and be able to listen. And if you have somebody who is interested in doing this as a career or as as their own practice, even if they're, PTs or, people who normally work on bodies. So send this to them and have them let them have a listen and see if they're interested in learning more about how the body is integrated. It's not compartmentalized into mechanical and then neurological. The mechanical affects your neurology. And so this has been a fascinating listen. So I appreciate it, Neal. Yeah, thank you so much.
All right. Thank you. Thank both of you for being here. Thanks for clarifying. That was good.
Thanks for joining us on another episode of OsteoSignal with Neal D O'Neal. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D O'Neal.